Hello, everyone. My name is Corey Del Bianco, and I'm here with Dr. Lerner. We're going to be talking about bladder health for Bladder Health Month this November. And we're going to be touching on a couple different topics. I'm really excited to have you here, Dr. Lerner. First, we're going to start out with what exactly is interstitial cystitis and what are some symptoms to look out for?
Yeah, interstitial cystitis is a little tough. There's sort of different categories, if you will, and interstitial cystitis falls into what we call the bladder pain syndrome. And we have an algorithm at the AUA that was developed that categorizes patients who feel that when their bladder fills, they are uncomfortable. And when they empty their bladder, they get relief of their symptoms. So, looking at that sort of overall, it's pain with bladder filling that is relieved with urination or voiding. The thing is that there's a more pathologic thing with interstitial cystitis where there's actually an abnormality of the lining of the bladder. And urine, which can be very acid and irritating, we believe it gets through the lining of the bladder and into the more of the meat of the bladder, and that can cause inflammation. And that can make the bladder hurt. It can make the patient uncomfortable. It can also mean that inflammatory process, because the bladder is supposed to be stretchy, right? It's supposed to be able to stretch and empty and stretch and empty. It's supposed to be elastic. So if you have a lot of inflammation in that part of the bladder that's supposed to be stretchy, and inflammation isn't stretchy, then as the bladder stretches, it becomes uncomfortable. And that makes patients want to empty. But there's another part in this bladder pain syndrome where a patient has a sensory feeling. So they sense a fullness of the bladder, but the bladder itself can look quite normal. So those patients fall into a little bit of a different treatment pathway. So they do perceive their bladder, they feel their bladder, and that is uncomfortable to them. But when we look inside and look at the bladder itself does not look abnormal. And that falls into this other pain spectrum where there's something about these patients and the way their pain receptors fire, how their brain processes pain. And we have to approach those patients a little bit differently. So it gets kind of complicated. And depending on the algorithm, we start with the same things for everybody, making sure that there's not blood in the urine, making sure they don't have an infection, making sure that there's not something pathologic going on. And then if they do, then we break down these different pathways and look at what it is that we can do to help treat symptoms.
So, how are you diagnosed with this, and how exactly do you treat this condition?
Well, diagnosis. So when patients come in, and what I tend to do is I print out the algorithm that the AUA has. There's just this one-page algorithm. And I find that patients who suffer from this, they're really seeking information. And they also want to feel and need to feel that they are part of a known disease process. I think that this is something that can really be so frustrating to deal with every day. And a lot of people aren't really comfortable treating it. So I feel it's very empowering. I have a whole bunch of the algorithms printed out, and I give one to the patient and I say, read that top box. And does this sound like you? And it is that box where it says, this is what the symptoms that the patient presents with. And they say, yes, this feels like me. And then we go through the algorithm together and show them, okay, that things like stress management, things that can really upregulate certain hormones and neuromodulators and things in the body that can happen with stress response and others can exacerbate symptoms. So and they know that. They actually know that without me telling them that. So we'll go down that path and sort of feel out where it is that their symptoms get triggered. So interstitial cystitis can be they can have flares. So they can get under good control for a while and then develop flares. Treatment really depends on which side of this algorithm you go down. For some patients, it is really learning how to disassociate from their bladder. So it can be stress management, it can be acupuncture, it can be things that fall into that Meditation can be very good into keeping themselves from escalating when their symptoms start. So we can see a lot of good results with that. Biofeedback, that all those things can help. Some people, there are definite triggers. Triggers can be alcohol, smoking, foods that can be very acidic in the bladder, produce a lot of acid and make the urine more caustic to the lining of the bladder, more concentrated. So there are things that we can do with modifications of the actual urine itself that can make patients feel better. So some of it is that dissociation and finding a way to get them out of that flare response. And some of it can be related to diet, and then we can get down into medication if we need to. We certainly try some of these other things first. If they have blood in their urine and they have findings of abnormalities of the lining of the bladder that looks really unhappy, we tend to use medications for that to settle that down. And that can be anywhere from a pill to medicines that we actually put into the bladder. There's actually a really good network out there called the Interstitial Cystitis Association. There are a lot of things in there that don't apply to every patient because every patient is unique. But what can be helpful for patients when they look at the ICA website is there's a lot about diet in there. So patients can look at that and see the things that are sort of known to cause issues with lots and lots of patients who have this diagnosis. And it can help them look and say, oh, you know what? That's true. When I eat or drink this, I do notice that my symptoms are worse, right? And so that can help guide them in some of those ways that we won't always necessarily have time to go over in the office.
Thank you so much. Now, is this something that can be cured? And if it goes untreated, will it affect other parts of the body?
It is not that untreated interstitial cystitis will directly affect other parts of the body, but it is true that we see some other problems that coexist with interstitial cystitis. So the bladder and the bowel have a lot of common innervation. A lot of times things that irritate and upset the bowel can irritate and upset the bladder. So we do see people who know that there's certain triggers for their gut, for their bowels, that can also have some ramifications for the bladder. We know that we see patients who have irritable bowel syndrome, and they can have a higher incidence of interstitial cystitis type symptoms as well. So that can be associated with that. We have good success with treatment of these patients. I've had excellent success, but I will say that every patient is different. Like you'll develop, like I will say that a lot of urologists develop their own algorithms in terms of the direction that they go. And I'm part of several like online groups of urologists, and it's interesting to see people's different concoctions or the different order that they go for how they treat patients. And we all sort of start at the same place. And then the more patients that you treat, the more you get this kind of gestalt of which of these different pathways this patient is going to go. And some of it is managing symptoms daily. Sometimes it's managing patients just when they flare and helping understand how we can control a flare.
So now going to the next topic, what exactly is a neurogenic bladder?
Oh, wow, neurogenic bladder. So that's kind of tough because it would be a bladder that is behaving independent of the control of the brain. So I like to say that the bladder is like a horse in the gates at the horse race, right? The horse is behind the gate, and then as soon as the gate's released, it's supposed to take off. And if anybody's ever been to the horse races, then they'll see some horses they get into the gate and they're really like revved up and they're just waiting to go, and they don't want the jockey to sit on them, and they're just waiting, just give me the signal, let me go. Other horses just sort of saunter into the gates, and they're there and they're kind of hanging out, and you wonder if they're even going to win. Are they even going to run when you open up the gates? That's sort of how the bladder and the brain work. So the bladder actually wants to go all the time, but the brain learns how to inhibit the bladder. So we learn to toilet train. So we learn how to exert control with our brain on our bladder to say, I don't want you to release yourself until I tell you that you can release yourself. So patients can have urge symptoms. The patients who say, as soon as I'm about to put my key in the door, I have an accident. But if they sat in the car for another hour or drove another hour, they would be fine. So there's an interplay between, oh, I just got home, and what's the first thing I do when I go home? I go to the bathroom. And so whether or not people sort of inadvertently release this inhibition on the brain, or the bladder starts to fire and they don't realize that they can calm it down. So when we do bladder testing with patients and we see some of these contractions that we call uninhibited contractions, so the bladder is behaving independently of the brain. And if we tell them to suppress that and we see the contraction come down, then we know the brain and the bladder are coordinating together and that they can. And that's a sign that we can work with that patient on things like biofeedback and helping them understand how their brain can actually control their bladder. Neurogenic bladders, you don't have that same ability to control with your brain. So it could be happening because a patient's had a stroke. They've had something central happening in their head, or there's something along the course of the spinal cord, like spinal cord injured patients, so that the brain may have a signal and it sends it out, but it can't make it to the bladder because there's an interruption along the way from a spinal cord injury, or that the peripheral nerves, like what you can see with diabetics, where the brain is okay, the spinal cord is okay, but those nerves, when they get their way out towards those ends, are not as responsive. So all of those things fall into this category of neurogenic bladder. And so those bladders may either contract too much and you can't sort of exert your own control on it, or it can be a bladder that doesn't squeeze at all. So now there's no signal telling the bladder that it needs to squeeze. So the brain may be knocking at the door saying you're supposed to squeeze and you're supposed to empty, and it can't. So for us, when we see patients like this, we have to understand, what is their problem? Is it that they're going too much, or they're having incontinence, or is it their bladder isn't squeezing at all? And those are different treatment algorithms, of course.
Now, is there a procedure, or how are you diagnosed, and how is this treated?
Well, I think treatment is super complicated, but how do we diagnose it? So urodynamics is probably the mainstay of treatment for a neurogenic bladder. I mean, honestly, we use urodynamics to understand a lot of things about how a bladder functions. Typically, urodynamics are done in the office. There are non-invasive urodynamics and there are invasive urodynamics. And the difference between those is it can involve placement of a catheter, where a small catheter with a pressure transducer goes into the bladder and another one goes into the rectum or into the vagina. And that cancels out abdominal pressure, because some patients, they learn to push to void. They're pushing on their belly all the time. And we need to take that abdominal pressure out if we want to understand exactly how the bladder is functioning. So we need to have an abdominal pressure for that too. So there's invasive urodynamics where the probes are actually inside an organ space, the bladder and the rectum, the bladder and the vagina. There's non-invasive where we attempt to measure the pressure from the outside. And then when we see that, get that feedback, that can tell us how the bladder is behaving. And we can say to a patient, we want you to try to go to the bathroom now and see what happens when the brain is trying to trigger it. Is it actually causing a response in the bladder, and how robust is that response? And like I mentioned before, sometimes the bladder is behaving in an uninhibited way, and we tell them to tell the bladder to settle down, and we see if that signal can get there. So urodynamics is the mainstay of making a diagnosis, if you will. We have, we're beginning to see more and more home urodynamics. There are now new technologies coming out that could allow us to put a probe into the bladder, and then it just measures how the bladder behaves. The patient goes home and it just sends us signaling back, so we find out what's going on. I would call this very similar to like a Holter monitor, when you put a patient on a Holter monitor for their heart and then you send them away, and then all of the heart activity is recorded. So we're beginning to see more and more of those things for bladder dynamics as well, where it's recorded and then the device is taken out. So that is that is the most definitive way to diagnose it. We can suspect it based on other things, basically what is happening in real life with these patients. We can do trials of medications and see how the patients respond to medications, and those can sometimes be a surrogate and can lead us down a certain path. We don't always have to diagnose a neurogenic bladder. It's more about how do we help a patient manage it? So sometimes whether or not they have that diagnosis is irrelevant unless it is the way that they are presenting and they have no known neurologic injury. Then you would say, why is this patient now presenting with new bladder and maybe new bladder and bowel symptoms? And those things can start to make you think, do we need to make sure this patient is being evaluated for some underlying condition that they don't yet know about? Multiple sclerosis, some other things like that. So sometimes the bladder can be the first indication that something else is going on. So I do think we have to keep those things in mind. But if we know that a patient has a neurogenic bladder and they've had a stroke, or they've had a stroke and they have some voiding issues, it sort of is irrelevant whether or not it's neurogenic bladder. It's really about the management, and that's what we need to help the patient with.
All right, and now we're on to our last topic, UTI and bladder infections. So once again, what is that, and what are some symptoms to look out for?
Oh, UTIs. So UTIs are one of my areas of interest for sure. And I think we're learning so much about UTIs, and we could spend so much time talking about UTIs because some of the new information that we're learning is actually quite fascinating. A true definition of a urinary tract infection is that there is bacteria in the bladder that is causing symptoms. Now, there are uncomplicated UTIs and there are complicated UTIs, and there are recurrent UTIs, and there are catheter-associated UTIs. So there's a lot in the world of UTIs. Most UTIs are uncomplicated, and they involve the bladder, and they can respond to short courses of antibiotics. And that can be 3 days. And it's important that we treat patients with the shortest course that we can to treat the problem, because we are getting more and more issues with antimicrobial resistance. And we are in an era where there is not a lot of new antibiotic development happening. It's very expensive. New antibiotic development is very expensive. A lot of pharmaceutical companies can't afford it. And it is still sort of unclear what's going to happen out there in the world in terms of developing and supporting new drugs to come to market. So given that, people are moving towards new strategies, which would be in the world of prevention and in the world of vaccines. There are now 2 UTI vaccines in trial. One is a sublingual, goes under the tongue. Another one is an injection. They're both targeted for E. coli, which is our own bacteria that we have in our gut. And those are to reduce sepsis events. So they may not necessarily have an impact on the infection itself, but they could have an impact on the seriousness of the infection. So the thing is most UTIs are uncomplicated. When you start getting into the complicated or recurrent UTI, we really probably should see ourselves as a community and as a society moving towards doing a better job of talking prevention. Now, prevention could be related to fluid intake. There are women who can have infections pretty predictably after having sexual intercourse, and that those patients may take an antibiotic related to that. When you know that you can identify when a patient is going to develop an infection, and there are some patients who do, typically this is more common for women than for men in that regard, they can take a single dose of an antibiotic, or they might be able to do some of these things that change the composition of their urine to help prevent getting infections. Men can be more complicated because the source of their infection can be a bit different than what happens with women. In general, we talk about it all as being a patient's own flora. So the more standard cause of the infections would be related to bacteria that lives in a patient's vagina or bacteria that lives in a patient's rectum, and the ability of that bacteria to come across the lining of the bowel and get into the bladder or go backwards up the urethra. What's interesting about urinary tract infections is we're beginning to learn a lot more about the microbiome of the bladder. And there may be alterations in a patient's microbiome that make them more susceptible to infections. And this is actually a really exciting new development in the world of bladder health and understanding the bladder. And there are new technologies out there that can map a patient's microbiome. So you would submit a urine sample when you're healthy, and it will spit out this formula of all the different kinds of different bacteria and things that live in your bladder when you are healthy. Then if you're developing bladder symptoms, be it infection, or even if we're talking interstitial cystitis, like what we first started talking about, then you take urine during those times and you compare it to the urine that was done when you were in a healthy state. And you may be able to identify what the abnormalities are. And that is how we can really start to target interventions, right? Is it a particular type of organism? Is it an overgrowth of one versus another? Is it yeast? Is it a virus? Is it a bacteria? Is it a fungus? All of these kinds of things can be determined in these assessments of a patient's bladder milieu, if you will. And what is happy urine for you is probably going to be different than what is happy urine for someone else. And things like puberty or menopause might very much affect that, at least in women. And we know that to be true in terms of looking at how women present postmenopausal infections are more common. Bladder symptoms could be more common. Men, it may not be as hormonally driven, but it might be. So I think there's a lot going on in the world between the vaccines and between understanding the microbiome that may really drive change in how we address bladders in lots of ways, not just infection and not just inflammation like interstitial cystitis, but there is also suggestions that bladder cancer can be affected by the microbiome, and the treatments that we offer for bladder cancer can be affected by the microbiome as well. So I think this is a pretty exciting time in the world of the bladder. So it'd be interesting to see what comes out over the next few years for sure.
Then when should someone go see a doctor? What symptoms are they looking for to think that they might have a UTI?
If the pain is pretty severe and it's not getting better with like drinking more fluids and flushing out the bladder, if there is blood in the urine that they can see, then we call that gross hematuria. So hematuria, we have visible hematuria. Certainly if they have a fever, those are reasons to go seek out help. Women who get recurrent infections in particular, and sometimes with men as well, they may learn to take some over-the-counter things when they first start to get some twinges of discomfort that may make them think that they have a urinary tract infection. And they might try that for a day or two. So for patients who are used to addressing their symptoms on their own to start, that is not unreasonable if someone hasn't developed a fever and doesn't have a lot of blood coming out of their urine. But if after a couple of days it hasn't gone away on its own, then they would need to consider that a short course of antibiotics could be necessary. And some of those over-the-counter regimens are just not going to cut it.
And just one last question. Anything else that you want to mention about bladder health or anything about your expertise with the bladder?
Well, I think there's a lot about the bladder. I would say that, I spend a lot of my time in the UTI space, some in that bladder pain, interstitial cystitis space, but probably the majority of my time is spent around men's bladder health, which I think men in particular, we tend to blame the prostate for all of the voiding problems that men have. And a lot of times it's actually It's either how the prostate has affected the bladder or it is the bladder itself. And I think that out in the world where a lot of the discussion goes for men is towards the prostate. And while the prostate could be implicated, it really is the bladder. And I think women, they tend to think bladder and we tend to talk bladder. And in men, we tend to think prostate and talk prostate. But in actual fact, a lot of the times it's the bladder or how the bladder has learned to respond to the prostate in those cases. But plenty of times it's primarily the bladder. So I guess what I would say is when I see patients coming in and they're all charged up about their prostate, because that's the paradigm when I say to a male patient, it's actually not your prostate, it's your bladder. That just doesn't kind of register, right? Because we don't really think about it that way or talk about it that way in society. So I find that sometimes I have to undo things and change the way the patient is thinking about it. So if I were to impart anything on anybody that I think is really not discussed as well as it could be, is how the bladder is very important in male voiding as well, and it's not always the prostate.
Thank you so much, Dr. Lerner, for taking some time to talk with us. Stay tuned on the Urology Care Foundation Facebook, Instagram, and Twitter for more information over November and Bladder Health Month. Thank you so much.
Thanks so much. This was really fun. Thank you.